residents and my dear friends. Also, I would like to thank Team IMPAI who gave me an opportunity to give me a talk about common GI infection which is happening in children. It's really a great pleasure once again to deliver this lecture in front of my honorary professor, V.V. Vadrajan sir. When I did my pediatrics in Indira Gandhi Medical College, followed by I was along with the professor for almost a year in KKCTH. So it was such a wonderful time for the entire journey of pediatrics along with the professor. So many things we have learned through him, and it's really great honor for me to present in front of a professor. Thank you, sir. And to talk about this common GI infections in children, sir has given me a topic. I was wondering if this is such a vague topic to discuss, because in the post-lunch session to talk about GI infections, this is such a huge list of GI infections are being there, which is happening in the field of gastroenterology, right from pediatric, infancy, and also up to adulthood, and all those areas. There are so much of infections there. So how to tackle this as a family practitioner, how to analyze this basic problem when you are going to manage. I have planned my area of discussion in few areas, like common scenario what you are going to get when you are going to manage a pediatric population is acute gastroenteritis. Next to that, worm infestation, many of the patients will be having, but how far you are going to diagnose is the most important thing. And food poisoning, rarely we used to encounter abdominal tuberculosis, and many more common scenarios is happening. And some points about probiotics and what is the role which is going to have an impact in the field of gastroenterology when you are going to manage. Before starting my area of discussion, you all should remember about one important thing in gastroenterology is human gut microbiota. This role has been taken an enormous area of development, because now it has been considered as a separate system nowadays in the field of gastroenterology when you are going to talk on that. If you are going to look into this, it's almost around 10 power 13 to there are various gut microbiomes being prevalent in your human body. Almost around 10 power 13 to 10 power 14 microbial cells are being there. And it has been broadly divided into firmicutes, bacteria, and actinobacteria. So why I would like to point out this, right from a basic infancy, intrauterine period, and from infancy unto adulthood and to adult period, the entire spectrum of development, it is being completely influenced by your gut microbiome. In case it is gut microbiome, we need to maintain a proper gut eubiosis in order to improve this prevalence, in order to improve this gut nature in a proper manner. If this eubiosis, if it is going to get disturbed, what is going to happen? The dysbiosis is going to get started. Once a dysbiosis, if it is going to get started, what are the various problems you are going to get encountered? You may have infection diseases, you may have non-infection diseases. There are so many complications there to prevail in this field of gastroenterology. As we all know, starting from your mouth to anal canal, the entire GI tract is such a huge area, and there are a huge list of bacterial composition is being there. And basically, we should remember that one by lactobacillus as well as enterobacteriaceae. There are three major areas that to discuss. How much of amount of organism is going to get colonized? See, as we go down further, if you are going into the terminal ileum, if you are going to the distal part of your colon, the organisms is going to be more. So it will be around 10 power 13 to 10 power 14. In the initial phase, if you are going to be in the proximal stomach, if you are going to be in the early small intestine, will be in the range of around 10 power 6 to 10 power 7. So as the disease gets progressed, once a patient is going to get involved in this area, there might be evidence of worsening of events will be happening. So how the gut microbiome is going to get evaluated, that's the most important thing you should remember before taking on my discussion with this GI infections. So right from your breastfeeding, intrauterine period, as well as your diet and lifestyle pattern, your exercising, your daily routines and all those things is going to influence your gut microbiome in this area of development. So what is the main mechanism? What are the various things which is going to enroll is, there are mainly by metabolic or trophic or protective factors is going to get enrolled in your going to disturb your intestinal microbiota. What does this metabolic process? It is going to ferment your short-chain fatty acids, and it is going to provide a reasonable energy along with the vitamin as well as your mineral synthesis. And mainly as a trophic to proliferate and differentiate your colonic epithelial cells and proliferation of your intraepithelial lymphocytes. And protective, it is going to protect against your various pathophysiologic bacteria. And if you're going to look into the action of probiotic, without that, the intraluminal pH, if it is going to get narrow, the cytotoxic bacteria, if it is going to get involved, all those things is being taken care of, the protective effects of this by intestinal microbiota. Once if it is going to get disturbed or perturbed, that's the area where you are going to use your probiotics. So this is the most important thing we are supposed to remember about maintaining a gut eubiosis. After this brief discussion, so we need to take on the area of discussion about our various infections which is going to happen in the GI tract in pediatric age group. The first and foremost entity right from infancy is acute gastroenteritis. Acute gastroenteritis, there are huge list of etiological factors in India, but the one common important etiological factor what we are supposed to not forget is viral event, because around 70 to 80% of the population will be having viral diarrhea. That's the most common entity, and as of now in India, the rotaviral is one of the most common event. And for this rotavirus, as per national programs, we are having multiple, reasonable protocols of vaccination. So we can have a double dose regimen or triple dose regimen, where whatever the various vaccination regimens are there. So rotavirus, we should not forget when you are going to tackle a patient with infectious diarrhea. It could be because of viral, or it could be because of bacterial, or it could be because of protozoal, or it could be because of fungal, or it depends upon the various clinical presentation. You may be having varied etiology for your acute gastroenteritis. For example, we will take this clinical scenario. An 8-month-old baby who presents to us in the hospital in emergency with history of vomiting, along with after 6 hours of this vomiter, the baby started passing to have more watery stools. On examination, the baby is drowsy, sunken eyes, and skin pinch is slightly prolonged. So with this, what is your diagnosis? How much of dehydration? How are you going to manage this study? This is the basic clinical scenario. An 8-month-old baby who's a weight of almost around 7 kg. So this is another clinical scenario. You should not forget that. To a 10-month-old baby who presented to us in the background of diarrhea for the last 20 days. So I will take on this discussion. See, if you're going to look into this, acute diarrhea is nothing but you are passing minimum 3 loose stools. It's based upon your fluidity, your volume, as well as your number. It could be because of acute diarrhea, the event should not progress more than 14 days. If it is because of persistent diarrhea, if it is going to progress more than 14 days, along with no major other organ involvement. If it is going to be a chronic diarrhea, you may be having evidence of malabsorption and the diarrhea process if it is going to happen for more than 14 days. It could be because of protein, or it could be because of carbohydrate, or it could be because of fat, which is predominantly because of pancreatic involvement. There are so many etiological factors for chronic diarrhea. That's not the area for discussion right now. So we need to progress mainly for acute gastroenteritis. So how are you going to? This is one of the most commonly assessed problem. So high mortality is being reported because of this diarrhea under 2 years and under 5 years, almost around. If you're going to look into the mortality, there will be almost around multiple. Next to respiratory event, next to pneumonia, next to prenatal events like birth asphyxia, septicemia, diarrhea is still occupying the rate of hospitalization as well as the rate of mortality throughout the world is around 6 to 7% is still in the top place when you are comparing to other etiological factors. So one of the basic triggers, it could be because of gut microbiota disruption, mainly by your poor hygienic practices. You're not going to feed your baby with proper breastfeeding and early introduction of complementary feed. All those things, if you're going to use uneven milk for a longer duration of time and contaminated food preparation, these are all the various food triggers you need to remember when you're going to manage a patient with acute gastroenteritis. Huge list of causes are there. Viral even for corona, right now for coronavirus is being more discussed in this area, but pediatric coronavirus related complications, various papers being there to report back, not much of extensively studied. So there have been cases of the post-infectious IBA, that's a separate area for discussion, but you should remember that the most common etiology is mainly because of rotavirus, and next to that, it can be because of astro, adeno, coronavirus. So many etiological factors are there. And apart from that, the bacterial focus is one toxic entity we should not forget. It's mainly because of E. coli, and E. coli there are various subdivisions are there. And next to that, we can think in terms of your various organisms like Vibrio cholera. So many other etiological factors, Campylobacter jejuni, all of those things can be taken into account when we are going to tackle bacteria. Protozoal factors like Giardiasis, Cryptosporidium, so many etiological factors are there. And other things like your Shigella and Salmonella, you are not supposed to forget, because that may cause a bloody diarrhea and it may lead to severe colitis. That is also one more etiological entity to be discussed. And over the diarrhea, these factors is going to get transmitted. As we all know, this one person to another person, the new host is going to get involved by your fluids, fingers, flies, and feels. All those things, if you are not going to tackle properly, there is another person, there is high possibility for this to fecal-oral transmission for this event to get progress. And as we all know that the main diarrhea we should not forget, one is by osmotic diarrhea. and another one is by secretory diarrhea. So for example, osmotic diarrhea is nothing but your rotavirus, and secretory diarrhea is nothing but you are going to because of your toxin which is going to get released, because of your cyclic AMP pathway which is going to get activated. What is going to happen? It is going to destruct your enterocyte. That's the area where you're going to have secretory diarrhea because of your E. coli and Vibrio cholera, and invasive diarrhea like your shigellosis as well as your Campylobacter. Basic things, if you are going to look into that, the secretory cells from the crypts will be replaced mainly by your absorptive cells. So what is going to happen? The rotaviral diarrhea, your absorptive cells is mainly replaced, going to get replaced by your secretory cells. So once the secretory cells gets replaced, so there is high possibility for the patient to go for osmotic diarrhea. What is this osmotic diarrhea? The very important point that we should not forget. Most of the time the osmolarity will be very high in this case of diarrhea if you are going to check. And most of the time the baby will be presenting to you as with a perianal excoriation for osmotic diarrhea because of lactose intolerance, so many other factors, and rotaviral diarrhea is also one more common etiology. And in case if you are going to eliminate the trigger, if the baby is going to breastfeed, for example lactose intolerance, if you are going to remove the trigger, the diarrhea is going to come down. So by fasting your diarrhea is going to get improved. That is nothing but your osmotic diarrhea. This simple thing we should not forget, but there are so many other investigation processes that's out of discussion. And next to that, by secretory diarrhea, even if you're going to eliminate your diet, the diarrhea event will not going to get stopped, and the event is going to get worsened. Even with that, the toxicity, the toxic prodrome, the osmolarity, all those things is going to get high in secretory diarrhea, for example, Vibrio cholera and all those things. So what is going to happen? For example, in secretory diarrhea, the cyclic AMP pathway is going to get activated. So there will be evidence of inhibition of absorption of sodium and chloride from your cells of villi, which is going to stimulate the secretion of chloride from your crypt cells. So thereby you are going to have your worsening of events in secretory diarrhea. What is going to happen in invasive diarrhea? So it is going to completely disrupt your mucosa. It is going to completely disrupt. Predominantly invasive diarrhea will be localized in your large intestine, not predominantly in small intestine. Because if you are going to look into shigellosis and all those things, the colitic picture, the severe enterocolitis can happen, but usually the severe colitis will be in the large intestine, and that's why the reason the baby will be having evidence of tenesmus. Tenesmus is nothing but a crampy pain which you can able to feel in the rectum, and the baby will be having evidence of rectal prolapse because of that. So that is the area we should not forget. If the baby remains toxic, high fever, if your counts is going to be high, and there is evidence of dehydration in the background of blood and mucus in your stools, that shows clear pointer that the baby is going to have a worsening of event. It could be because of dysentery or it could be because of diarrhea. That shows the evidence of blood and mucus is going to be present. That is one of the most important things we should not forget when you are going to manage it, invasive diarrheas. Basically, what is that we need to say as a pediatrician, we should not forget about any baby who are going to present you in casualty. How are we going to assess that if the baby is going to play well, if the pulse rate, vitals, BP, sensorium, activity, skin turgor, urine output, all those things are fine, nothing much, no much signs of dehydration. But if the skin turgor is going to go down, if all those things, if urine output is going to come down, your pulse rate is going to, if there is evidence of shock, we need to delineate whether we are going to chapter with isotonic or hypotonic or hypertonic type of dehydration which is going to get happen. So basically we need to categorize as mild dehydration or moderate or severe dehydration. That's the most important thing once the baby is going to land up with diarrhea. So clinical presentation, assess for pain, what is the color of stool, whether it is admixed with blood, and evidence of fever, and clinical examination, evidence of dehydration, pointers that what are we supposed to tell, and assess for evidence of complications. What are the various complications? It could be because of metabolic complications, or because of the dehydration per se, or the baby because of continuous fluid loss, maybe going into state of hypotensive shock, hypovolemic shock, and next to that, extra organ system involvement like convulsions, post-diarrheal paralytic diarrhea because of your potassium it is going to get down, and followed by the baby may show evidence of continuous excoriation. For example, in case of lactose intolerance, there might be evidence of failure to thrive. If you're going to look into the failure to thrive, there are so many criteria there to diagnose that, and apart from the baby is going to present with evidence of malnutrition. It could be moderate malnutrition, or it could be because of severe acute malnutrition in which your metabolism circumference, if it is going to come more less than around 11, so that shows the evidence of pointer that the baby is going to land up with severe acute malnutrition. There are various complications being reported when you are going to manage a patient with acute gastroenteritis in the background of severe dehydration. So this diarrhea is a vicious cycle which will predispose to malnutrition, and malnutrition itself will further worsen, because as we all know, measles is also one of the common entity in which not only based upon the rashes, some pediatric babies even reports as diarrhea. So why we should remember that? That's why we will be giving vitamin A and other support, because in order to stimulate the colonic epithelium, not only vitamin A, folic acid and all those things can be used if you want to protect your gut in an effective way for you to manage efficiently in your patient with evidence of chronic diarrhea. So 4 important signs: your sensorium, your sunken eyes, your drinking, your skin pinch, all those things. And management of dehydration, simple thing, plan A, if the baby is active, playful, running, jumping, all those things means nothing much, give ORS, wait and watch, look for the alarming factors, counsel the patient, counsel the parent, and in case if the even worsens, bring the baby to hospital. So moderate dehydration, we can give up to 75 ml per kg, either by oral or you can give by IV. Always you should recommend that we need to go for ORS in a low osmolar ORS which contains osmolarity of almost around 245, not with WHO based ORS which contains osmolarity of around 311. Because low osmolar ORS, if you are not going to lower the patient, it's too much of sodium. So that is why low osmolar ORS is preferred rather than going for a tetra pack of ORS or other things. Definitely not supposed to recommend when you are going, because as a tetra pack there are so much of evidence and papers that there to report the osmolarity being touched almost around 500 to 600. There are some papers being there to quote that. So definitely not much of tetra packs being recommended. So WHO based standard formulas or a low osmolar ORS formulas if you are going to manage a patient with moderate dehydration. That's the most important thing. We can go up to 75 ml per kg. For example, if the baby is around 10 kg, we can give up to 750 ml over a period of 4 to 6 hours. That's the criteria we can take into account. In between area, if the baby is not improving, we can simultaneously calculate by your IV fluids also. And once the baby is going for severe dehydration, as I told you, based upon your shock parameters, your irritability, lethargy, drowsiness, your skin pinch, your reduced urine output, there are so many pointers starts from head to foot to assess whether the baby is progressing to severe dehydration. Is there, like a mathematics, easily we can able to recognize the complication. But once the baby is out, fast we are going to intervene, because once the baby is going for severe dehydration, there might be evidence of electrolyte disturbances, there might be evidence of other events. So we need to tackle all those things promptly if you want to manage a patient with this evidence of severe dehydration. So 30 ml per kg of Ringer lactate is ideal fluid, because Ringer lactate contains all the electrolytes and sodium is almost around 130 in 1 liter of solution. So better to give Ringer lactate to start 30 ml per kg, followed by 70 ml per kg over a period of 5 hours, 30 ml per kg in the initial period of 1 hour. That is the usual protocol if you are going to manage a patient with severe dehydration. So basic fluid loss, you should remember that no signs means the weight loss is going to less than 5%. Some signs means the weight loss is going to be around 5 to 10%. The severe dehydration means the weight loss is going to be more than 10% of your body weight. So basic management, as what I discussed, clinically recognize and manage. Always you should not forget, in infancy you need to continue mother milk not supposed to stop, and we can enhance the quantity of mother milk also, because if the baby is having more and more loose stools, don't think that we are not supposed to give any oral diet. We need to give reasonable oral diet in order to maintain a gut eubiosis along with the basic medication, other support. What are the things we are going to? Is there any role of antibiotics? Yes, of course, when you are going to manage a patient with low AGA symptoms, when you are going to tackle a patient with secretory diarrhea, like cholera or some other things, when you are going to touch, that's the area where you are going to consider antibiotic. There is definitely a role of zinc to be considered in pediatric age group. Less than 6 months and more than 6 months, 10 milligrams and 20 milligrams of dose for a period of almost 14 days, because in order to improve the gut maturity, your gut factors, your MALT, your gut association factors, your mucosal associated lymphoid factors, there are so many things to proliferate in order to inhibit your further bacterial defense action. All those things has to be enhanced, means you need to give zinc, because it is going to prolong the next diarrheal cycle also, almost around 3 to 6 months. If you are going to give zinc for a period of 14 days, the next diarrheal event, the possibility of recurrence will coming down for more than 3 to 4 times in that pediatric age group. That's why we need to consider. And other micronutrient deficiency, if this is going for persistent or chronic, for example folic acid, for example vitamin A support at a dose of around 25,000, 50,000, all those things we should not forget when you are going to manage the acute gastroenteritis, or if the patient maybe is going to land with persistent or in the background of chronic diarrhea. The various drugs are what I discussed, so we can go for ciprofloxacin if you are going to consider sugar or other things. vitamin, micronutrient support, zinc, I told you. And vaccination, we should not forget vaccination, very important thing. And always rotaviral vaccination, if you are planning to initiate, you need to initiate at around 6 weeks of age. And there are so many criteria based upon your American society as well as your Indian society, also based upon your European society. There are various criteria for rotaviral vaccination, and maximum period we can go up to 8 months nowadays, what they may mention. But usual consideration, we need to consider all doses not to exceed more than 6 months of period. And if you are going for Rotarix or Rotatec, which is tetravalent or even monovalent vaccination strains, which you are going to consider, we need to give 2 doses or 3 doses of 2 doses of Rotarix or 3 doses of Rotatec as a oral regimen we can consider, which is going to start from 6th week of age, and 10 and 14 weeks we can consider if you want to vaccinate your child. Because rotaviral death is very common, because rotavirus will be having a triad of symptoms, can present with fever, abdominal pain, and profuse watery diarrhea, and rapid worsening of symptoms, high hospitalization rate throughout the world. It has been proven. So there is high curability, there is reasonable response when you are going to use a rotaviral vaccination. That is why the significant efficient beneficial role is going to be there for rotavirus. And breastfeeding to be continued, other nutrients, micronutrients, and take care of hygiene, safe drinking water and hand hygiene. And as of now, the coronavirus protocols, all those things to be taken care when you are going to manage a patient with acute gastroenteritis. Briefly about other events like your bacterial focus, like your salmonellosis or Shigella, you should remember that there are various toxins is going to get released based upon, if you're going to think in terms of salmonella enterici, it's going to mimic your typhoid, and typhoid fever itself can present like diarrhea as a low entity, and it can, its initial presentation will be having rashes, the rose spots and all those things is going to get formed. But there it's once the salmonellosis, there might be evidence of bloody diarrhea can happen, but it's still in the lower side when compared to shigellosis. So once a baby is going to land with Shigella, as we discussed, there are 4 major species like dysentery, flexneri, boyd and sone. And sone is slightly in the lowest side when compared to boyd and flexneri, but this is significantly will cause a toxic colitis, which means like your antibiotic associated colitis. When you are going to manage a patient with antibiotic associated, that's one form of entity when you are not supposed to forget. I have seen many patients, many babies, even after amoxicillin will be landing up with this antibiotic associated colitis. As we all know, antibiotic associated colitis, the common molecules what you are going to use is vancomycin or metronidazole. How to feel that phenomomycin is other molecule being tried in market, but how far it is going to be studied in pediatric age is a questionable issue. The safe one is vanco and metro. We can consider if you are going to manage an antibiotic associated colitis for a period of around 5 days initially, and followed by of a period of around 10 days. Depends upon the severity of this antibiotic colitis also when you are going to manage. Other infections like your protozoal focus, when you are going to think like your Entamoeba histolytica, like amoebiasis. If once you are going to think about amoebiasis, the most important thing is either because of your bacillary dysentery or it will be because of your liver abscess. Today I have taken an area of discussion not about C, even though it's a GI infection, I didn't have much of discussion about the liver. It's because it's a separate area to be discussed for your hepatitis A, B, C, D, E and liver abscess, all those etiological factors along with cholangitis and all those things that has to be addressed separately. Only our GI infections, if you are going to get focused, amoebic dysentery, if you are going to think about that, is mainly by your when you are going to manage that, might be evidence of possibility of worsening of events, and that shows evidence. So sometimes this babies can, mainly the infection is going to get transmitted by your cyst, because usually it's going to resist your cold as well as the chlorination other process, and person to person transmission can happen when you're going to manage a patient with amoebiasis. And your Giardia lamblia, because it's another important infection which will predispose in immunocompromised children. Like if you are having severe combined immune deficiency, for example IgA based deficiency, that is hypogamma globulin, all those conditions there might be evidence of your Giardia lamblia to get worsened. And you should not forget, it will be existing in trophozoite as well as cyst form. It should be, and it's the most common intestinal parasite is going to get exist, and cyst is always resistant to your chlorination and other process. There are various etiological management. One is by Campylobacter, we can try erythromycin, Clostridium difficile, that's what I told about antibiotic colitis, we can go for your metronidazole or vancomycin. E. coli is another important entity I forgot to mention here. There are 5 events. One is intra-aggregative, intrapathogenic, intra-invasive, and there are one more thing is intra-hemorrhagic. So enterohemorrhagic E. coli, if you're going to think, it's mainly by 0157H7 process, which is predisposing to your hemolytic uremic syndrome. We should not forget that. And E. coli, there are most common etiological trigger. Enteroaggregative will be having a minimal invasive infection, and enteropathogenic also will be having a minimal invasive infection, but not more than that. But enteroinvasive E. coli will always mimic a shigellosis type of event, which will predispose to a severe worsening of events because it is going to disrupt the membrane. A severe colitis, a severe gastroenteritis, a severe enterocolitis can report once a patient is going to land up with enteroinvasive E. coli. Pseudomembranous colitis, I have been discussed, is mainly by the toxins what is going to related by your antibiotic associated event, and apart from that the various management protocol is there when you are going to manage a patient with pseudomembranous colitis. Next common area for discussion after this acute gastroenteritis is worm infestations, which frequently we used to encounter in the pediatric age group, and it's very difficult to tackle and very difficult to recognize. Next to that, it can predispose to mild infections, and it can predispose to severe infections, and sometimes it can predispose to abdominal colic. Abdominal colic worsening even that might be predisposing to surgery. 3 days before, I have seen a patient who had multiple ascariasis who was being subjected to a surgical intervention. And next to that, many times we have been reporting worm infestation mainly by your Echinococcus and other things. Echinococcus, as we all know, it's dog type form where we have in multiple areas, either by your liver as well as your lungs, multiple area of involvement there. And these are all one of the, because our chosen topic is only common GI infection. That's why I not focus more on that. If you want to look into this common GI, this is one very clear picture. This case scenario, a young boy who is going to present with evidence of vomiting. In that vomit, you are going to see almost around a 10 centimeter long worm. It's very clear pointer that we are going to tackle with ascariasis. So once slides are not changing. Okay. So once you are going to tackle with ascariasis, you should remember the basic life cycle. How does it going? Because it's going to harbor in your intestine. So how does it going to happen? The larva which is going to get released, and followed by when you are going to ingest the larva, what is going to happen? You are going to, it's by a fecal-oral route of transmission. So when you are going to ingest the larva, there might be evidence of your eggs to get hatched up in the small intestine. Predominantly in the small intestine. That shows the evidence that the baby is going to have worsening of ascariasis. Ascariasis will predispose to a Lafleur syndrome, which is mainly by your eosinophilia, a pulmonary infiltrate. You are going to have persistent cough. So that's the area of clinical representation. You can able to represent a big worm along with the Lafleur's like event, along with the basic diarrhea and other process can be settled in, along with abdominal pain. So there are multiple medications are there. You can try albendazole safely, or you can go for mebendazole. 3 days regimen can be tried 100 milligrams or 400 milligrams of albendazole stat dose, or we can go for so many other neomolecules like pyranil pomade, other things. Not neomolecules, pyranil pomade can be tried. And when you are going to think in terms, the basic complication like intestinal obstruction, which deserve a surgical intervention, you should not forget. And malabsorption is one of the common pointers that we should not forget, because and intermittent pain also can be reported when you are going to use that. And another case scenario in this young girl who presented to us with the evidence of severe abdominal pain on and off, but there is no significant lymphadenopathy or hepatosplenomegaly. She is markedly pain. And if you are going to look into this hemogram, hemoglobin is almost around 6 grams, and eosinophilia is almost around 8%, and the MCV is almost reduced. So this shows the evidence of microcytic hypochromic. What is the reasons? Mainly because of your ankylostoma duodenum. So this is the area where it is going to launch in your small intestine in your duodenum. So how does it going to happen? Mainly when you are going to walk with your barefoot. When you are going to walk with your barefoot, there is high possibility for this ankylostoma to enter into your GI tract, and that is going to harbor the further infection. So in this area we can use praziquantel, pomade, and all those things can be used in the management. So this area, this girl mainly presented to us with evidence of severe anemia. Hemoglobin has almost dropped. So we should not forget to treat the iron deficiency when you are going to manage a patient with this kind of presentation. Another case scenario, this very common scenario, a young boy who have frequent perianal itching, always used to put hand in the anal canal followed by worsening of events. It's nothing but roundworm we are going to tackle. I mean pinworm. It's Enterobius vermicularis. As we all remember that this is how, because it's going to harbor its eggs, harbor larva mainly in your perianal region, followed by, once the baby is going to get scratched into that area, followed by ingestion. There might be evidence that the eggs is going to hatch up in your intestinal area, intestine. So it can be a painless perianal itching, a post-sleep pattern, and asymptomatic event. Sometimes the patient will be landing up with the diarrhea and other process. So you should not forget to tackle all these common infections when you are going to manage. And next to that, the tapeworms and other things. Echinococcus is another important area, because identity cyst frequently will be reporting in pediatric age group, but human beings will always be considered as an intermediate host. Dog and snail can be considered as a major host, and there are medical management for longer duration of therapy, and you can go for surgical incision, or you can go for percutaneous aspiration. There's nothing but there are so many things. Is there Echinococcus granules? It's a vast area to discuss. Followed by, even for the radiologist, one of the complex area to analyze. That's a separate entity, and we should not forget any patient who is having GI as well as respiratory is having evidence of in this area to cattle residing area being locating, means there is high possibility for this patient to land up with Echinococcus. We can able to identify the cyst very promptly in your imaging. Next to that, another common interesting event is abdominal tuberculosis. If you are going to think about this, abdominal TB, around 10 to 15% of the population can report next to the pulmonary tuberculosis. But how is it going to disseminate? It can be a respiratory, through respiratory tract, or it could be because of your Peyer's patches, which is going to get involved in your terminal ileum. And next to that, it could be because of your miliary spread, because of extensive hematogenous focus. All those areas can be addressed. But neonatal tuberculosis is a separate entity, mainly by a perinatal transmission. It's going to involve the liver. It's a separate criteria. And apart from that, abdominal tuberculosis, if you're going to think, it can be a huge list. It could be a peritoneal form, or it could be because of your organs, or it could be because of your luminal tract. If it is going to involve your lumen, it can be in esophagus, your stomach, or small intestine, large intestine. Predominantly the large intestine is going to get harbor. If it is going to be in the terminal ileum, ileocecal region, it is going to get involved. If it is going to get involved in the ileocecal tract, why? Because the M cells is going to be abundant there. The Peyer's patches is rich in that area. So that's why when you're doing a colonoscopic examination, that shows evidence of ulceroproliferative lesion, which mimics a cecal malignancy. Even in pediatric age group, many babies we are being seen that. And next to that, so how are you going to manage? We can go for the regimen as per the guidelines now, what they mentioned, even RNTCP protocol, 6 months of the regimen, 2 HRZT plus 4 HR. But abdominal TB, still we can consider a treatment protocol almost around 9 to 12 months, intensive phase of around 2 months, and this one, in continuation phase of almost around 9 months we can continue, and 9 to 11 months of protocols is always better to follow if you're going to manage a patient with evidence of abdominal cocoon and all those things. Abdominal cocoon is nothing but with evidence of persistent mactal lymph node because of your tuberculosis. There might be evidence of intestinal obstruction, pseudo obstruction, other presentation can happen. And next to that, once the baby is going to have evidence of bloatedness because of your ascites, it's nothing but a wet form of your peritoneal nature. Once the baby is going to take into the wet form, you need to give the medication for a longer duration along with your nutrition and all those things to be taken in a prompt way. And never forget, any baby who is going to land up with tuberculosis, when you're going to start the patient on regimen, always we need to make sure that the liver function is to be good, and we need to check whether the viral markers, everything is negative, because most of the babies who have been started on ADD, within a few days of time, I have seen some patients who have been reported with the evidence of jaundice. We should not miss, and there is high possibility because of drug-induced liver injury will be predisposing to liver failure. And we need to give the maximum liver support along with ADT, all those things to be encountered if you want to manage a patient with this gastrointestinal tuberculosis. By TB lymphadenopathy is very common. Mesenteric nodes will be frequently involved. And next to that, when you're going to manage a patient, TB peritonitis is also, as I discussed, the wet and dry form. You should not forget when you're going to manage. And next to that, a small simple area to discuss is your food poisoning. Food poisoning is mainly various etiological focus are there. Once you're going to ingest some food, you're going to harbor an infection. So what are the various food things which is going to have? Suppose usually within a span of 6 hours, if you're going to have food poisoning, it's mainly by a Staphylococcus aureus or by your Bacillus cereus. If you're going to have contaminated milk and other source, it's mainly by your Staph aureus. And what is this Bacillus cereus? Nothing but a Chinese restaurant syndrome. If you're going to have your fried rice and other things, there is high possibility for you to land with Bacillus cereus. And salmonellosis is mainly because of your poultry, contaminated eggs and all those things, meat, fish and all those things. And next to that, if you want to focus about this, so what are the various mechanisms is mainly by the production of toxins. That's dietetic toxins. It's mainly by your Staphylococcal aureus poisoning, which is going to get reported, and it can happen in your CNS. It can act in your intestinal tract. That's why the toxin is going. The baby may go for a toxic presentation. A toxic encephalitis like presentation can happen once a baby is going to land with this kind of food poisoning. And another food poisoning that when you're going to consume honey or something else, you should not forget is botulism food poisoning, because it's going to have a neuroparalysis and other things. That's the area, because these are all the common infections: Clostridium welchii, Clostridium botulinum, and so many Bacillus cereus, Staph aureus, and Salmonella. These are all the common events which will predispose to food poisoning. How to tackle proper? We need to check adulteration practices to be minimized, and safe hygiene practices, and food consumption, all these things. And if you are going to try the food for the first time, you should not take it every branch at one point of time. That's the most important thing. Bacillus cereus enterotoxins, as we all know, one is by emetic form and next one is by diarrheal form. This is mainly by your fried rice which is going to get consumed. So food poisoning, various etiological triggers, we need to analyze and we need to manage symptomatic support based upon your clinical presentation. Before winding up, few points about your probiotic. You should not forget, when you are going to choose your probiotic, there are so many things are there. Yeast derivative, your bacterial derivative, so many focus are there. It should be a human origin and it should be a non-pathogenic, and there are so many mechanisms of action is there for probiotic, starting from your various enzyme production. For example, your bacteriocides, your short chain fatty acids, your lactic acid formation. So much of enzymatic production is there, and it should be non-pathogenic. There are so many probiotics being studied. For example, right now we can consider Lactobacillus rhamnosus GG, LRGG, or Saccharomyces boulardii, which is being used for longer duration of time, which is mainly by a yeast derivative. It will improve gut dysbiosis, which will aim to maintain your eubiosis. There are so many things that you are going to manage with probiotics. So, probiotics is going to have a beneficial effect to your host. And what is this prebiotic and what is this symbiotic? Prebiotic is nothing but a non-digestive source of carbohydrate which is going to have a support for your probiotic. Nothing but a fructooligosaccharides, plus inulin, galactose, so many other things which can be considered as a prebiotic. And probiotics and prebiotics will not be combined, and always it's better to go for a single strain of probiotic rather than going for multiple strains when you're going to manage. Starting from your basic event, there are so many things. And one more thing before winding up, I forgot to mention, H. pylori infection in children is another common area we should not forget, because peptic ulcer disease in pediatric to adolescent age group being reported, triple drug regimen, quadruple regimen being tried, but triple drug regimen is very safe if you want to address a patient with H. pylori. As we all know, that is also one more common entity we should not forget. So, before concluding, we need to analyze the patient, look for evidence of worsening of events, see whether the baby is landing up with evidence of basic focus like gastroenteritis, or because of your food poisoning, or because of worm infestation. What is the nature of presentation? Which system is being predominantly involved, your upper GI tract or lower GI tract? What is the nature of diarrhea? All those things, and proper anti-aging and prevention, all those things we're going to tackle. The possibility of worsening of this gastrointestinal infection definitely will be minimized. With this, I am happy to rest my presentation. Thank you all for your patience.